Okay, we are going to get started. So whenever you're ready, doctor, go ahead.
Okay. Well, I was brought here today by a kind of combination of little mishaps, I believe. Unfortunately, your speaker that was scheduled for today had to bail out, and unfortunately, I'm the new guy in town. So guess who gets to replace and put on the talk for you today? But I thought I'd share some things with you, very basic urology things. Some of them are related to all ages of patients, but a lot of them are related to the elderly patient. And so, I wanted to tell you, I just joined the VA 4 weeks ago. I was in private practice here in San Antonio for 34 years. Did my residency here at the VA, and Department of Urology and medical school here. So very familiar with this institution, but new to it, and it's quite different from when I was here. So I wanted to just go over some things that, and since there are not very many of us, feel free to stop and ask me questions whenever you want. So they say you should always kind of open your presentation with a shocker, and so I thought, well, this is a shocker. Here's something that when I gave this talk to nurses previously, I always told them it's so important to pull back the covers and see what's going on with the patient. You know, we're so oriented toward making sure everything gets into the computer, that we answer all the questions, that we finish all the templates, that nobody examines the patient anymore. Same thing if they show up into your office and you need to, you're doing an exam, pull down their pants. It's going to be one of the few chances that you're going to have to do that. So many elderly men, elderly Hispanic men in particular, don't ever show up for these kind of exams. So you'd be surprised what you find when you either pull down the pants or pull off the covers. This is a process called paraphimosis. You may remember this is an uncircumcised individual. The foreskin has been pulled back, and it hasn't been pulled back down. It's not uncommon when they admit somebody from the emergency room, they pull back the foreskin to put in a Foley, right? They don't pull the foreskin back down. 2 hours later, it'll look like this. And often they'll say, well, I think he got bit by a bug and he's got some swelling on his penis. If you ask him if he's circumcised and he says no, that's what this is. It's the paraphimosis. It's very important when the foreskin gets pulled back to always pull it back down. So this is kind of how you reduce it or how you make it better. It requires a fair bit of pain medication before you start this process. You put your fingers on the foreskin and your thumbs on the glans penis, and you push and pull at the same time. And after a significant amount of screaming, both yours and his, it will reduce most of the time. If it doesn't, it requires a little bit of a surgical procedure. But again, these can be easily handled if they never occur. So pulling the foreskin back down, I think, is a key feature here. So this is this is a phimosis as opposed to a paraphimosis. If you go tell the nurse, please put a catheter into this patient, and you have an exam, and you'll know that she's not going to be able to put a catheter in this patient, nor are you, unless you do a little slit of that foreskin to be able to see the meatus. So this is, again, something that you would find if you examine the patient. So another thing is you often hear, you've admitted somebody to the ER, and they said, we had no problems getting the catheter into the guy, but he's having a little bit of pain now, and his urine is kind of red in the tubing. So I think you need to ask them, is that where exactly did you put that Foley? Where did you blow up the balloon? And so, when you see this patient up on the ward, you need to just grab the tubing. If you pick up the tubing and the urine moves, there's a good chance that the Foley's in the right place. If it doesn't move, there's a good chance it's not in the right place. So the column of fluid has to move. If it's not moving, it's in the wrong place. So the next thing you could do, or maybe it's plugged. It could be plugged with a clot. The next thing you do is just irrigate the catheter. If it irrigates easily and everything starts moving, the patient gets out of pain, that's fine. But the fact that there is blood in the urine is always a concern that the catheter was put in the wrong place or the balloon was blown up in the wrong place. If you find blood, it may be necessary to put a bigger catheter in there so that you can irrigate, because you can never irrigate a 16 French Foley for blood. It's almost impossible. And so, I think sometimes and we'll go over some catheter choices, but a 3-way Foley catheter works great. You just have to make sure you get the clots out before you start that. So again, very important, good catheter care. Sometimes we have a Foley put in, nobody ever looks at the Foley the entire time the patient's in the hospital. It's important to keep it clean. It's important that the bag be below the level of the bladder. Urine does not flow uphill. God didn't make it that way, and it's not going to happen. And it's important that these catheters be kept off the tension. It's amazing sometimes you'll find that the Foley is stretched, across the handrail, over the handrail, and it's almost like a slingshot. It's so tight, and so if you don't take these catheters off retraction, long-term effect is this. This is urethra has been completely eroded by a catheter that's been on tension, and this is a significant problem. And so it's you usually see this in somebody that's had a Foley in for a long, long time. Again, they've never taken care to keep the catheter off traction, and these kind of things do occur. And then, of course, we all experience the traumatic removal of the Foley. There's a number of ways that can happen. Sometimes you're moving the patient off the gurney and onto the hospital bed. The patient moves over there, but the bag is still on the gurney, and the catheter is somewhere in between the two. And so the other thing that happens, not uncommonly, when the patients are on the floor, they're dragging their bag along. If they step on the bag, they can rip their Foley out. Most importantly, in our population of aging patients, is they get confused, whether it's from postoperative medications or just certain medications that we give them, or they have dementia, what have you. They grab on the Foley and they yank it out. And easy diagnosis: there's blood coming out the meatus, catheters over there with a balloon inflated. Never a good sign. Never a good sign. So that happens. No real reason to freak out. I think we all would suggest to you that you ought to try and put the Foley back in. Just make sure there's a lot of lubricant used. We suggest that you inject lubricant into the urethra and then try and put the catheter in. Nice gentle insertion. If you're not getting any place, then give us a call. And certainly any time that a catheter has been ripped out, remember there are gram-negative organisms all in the urinary tract. So you've got to be concerned about gram-negative sepsis. Watch these guys for fever and chills and hypertension. And so you might want to increase their vital signs for a good 8 to 10 hours after this has happened. So not looking under the sheets or pulling the pants down, this is a large scrotum, very large scrotum. I don't think you'll find this very often, but I use this for dramatic effect. We get called lots of times in more senior population of patients that they have scrotal swelling, penile swelling, and stuff like that. And I think, common things are common. So many of these people have congestive heart failure, have anasarca, have fluid all over their body. The scrotum is just some place that the fluid can transect through the tissues into the scrotum. Unlike the legs or the arms where you do have fascial compartments and you can limit swelling, scrotum is just a sac, so there is no limit to how much swelling you can get. Patient's not having any pain. If you can put your finger on the scrotum and create pitting just like you would with the leg, it's probably just edema. These things get corrected by elevation, diuresis, or correction of a medical problem if it's congestive heart failure or what have you. So again, ask the patient, are you having any pain? And if there's not, you got to think about things like, a painless hydrocele sometimes doesn't have to be fixed, but get them over to us and let us have a look at them. But these other kind of things, these congestive heart failure, liver failure, other things like that, they have to be fixed. Certainly cancer, when it involves the lymph channels, it's not going to get fixed. But that's another thing that can cause scrotal edema. If you don't look, you're going to miss one of these. And if you miss one of these, there's a good chance the patient's going to die on your floor. This is Fournier's gangrene. Usually you can tell because before you walk into the room, the smell will almost knock you off your feet. This is very common in our diabetics. It's very common in the elderly patient that doesn't complain. This is something that really, this is a surgical emergency. It's a life or death situation. You've got to let us know. We got to take him to the OR that evening, or that day, and get him corrected. Debride all that skin and he's got about a 50-50 chance of living when we find these. If we find them early, much better, but so often they come in, their blood pressure is next to nothing, and it's a bad situation. So just quickly, we're in the season of stones. This is hot weather. Right now, probably every third call we get from an ER is over a kidney stone or a stone that's passing. Women diagnosed with severe pain. And you know, what I tell my residents is, look, this is real pain. If you talk to a woman who's delivered a baby vaginally without anesthesia and had a kidney stone, they will tell you most of the time that the stone was worse than the delivery. So get some idea of what the pain can be like in these. And so giving these people ibuprofen or even tramadol is kind of, as we say in urology, pissing in the wind. I mean, you've got to help them with their pain. Give them something that really works. And again, in the situation if somebody has a known stone and they develop a fever, that is an emergency. We've got to do something. And so, you know, the first line of treatment for most stones is what we call medical expulsive therapy. You give them hydration, you give them something like tamsulosin or Flomax to dilate the ureter, and you hope that they pass it on their own, and of course pain control. If they don't pass it, then we usually use a stent. And these are little catheters that we put on the inside, and many times we'll leave a string attached to them so we can pull them out. Just make sure that you're careful of that string. Don't yank it out by accident, because these are usually put in under anesthesia. If you yank it out, we'll have to put another one back in. So, very common. Here's a classic X-ray. This is an unenhanced CAT scan, or you can put stone protocol CAT scan if you think it's a stone. It's a large kidney stone right here. All right, and then this is another one, another X-ray, and this is a ureteral stone. Now you see back here behind the ureter, the dilated renal pelvis. If there's infection trapped behind the stone, it's a dangerous situation because the infection goes right out of the renal pelvis, tubular backflow into the urine, sepsis. All right, so that's why we've got to put a stent that bypasses the stone, goes up the ureter, goes by the stone, makes a little J in the pelvis, makes a little J down here in the bladder, and then the urine can get beyond the stone. You treat the infection, they get better, then you can go after the stone. But you need to take care of that infection first. Okay, so let's talk a little bit about urethral catheters. Urethral catheters are something that, again, it's important that when they are put in on the floor that we use adequate, significant amounts of lubricant. Many of the catheterization trays now come with a syringe pre-filled with lidocaine, or with some lubricant that you can inject in the urethra. My suggestion is that you tell your nurses inject it in the urethra, not over the catheter, because as soon as they put the catheter in, the lubricant comes off, right? The urethra pushes it off, the catheter is going in the bladder with very little lubrication. So if you have your option, inject your lubricant down the urethra. It makes more sense. And then you start with the standard two-way catheter. And I always tell the nurses to inflate the balloon to 10 cc's. You know, they say 5 cc balloon on them. 5 cc's is real easy to pull down, pull out, pull into the prostate, cause problems. So 10 cc's is a little bit better and are less likely to cause a problem. If you're putting in a catheter, your nurse is putting in a catheter and they can't get the catheter in, have her tell us, or think about telling us, where they encountered obstruction. If it's right from the start, if the meatus is stenotic, let us know that so we can come prepared to dilate the meatus, put a catheter in. If it's halfway in, we'll take care of that as well. But if it's right at the bladder neck, the catheter is all but in, and you know the patient has BPH or the patient has a large prostate, think about using this Coude catheter. And all that is a little catheter with a curve at the tip, because what it does, it rides in over a big prostate, curls up over the prostate and into the bladder. And those are very nice to put in, and they're lifesavers at 2 o'clock in the morning. And you know, they always tell me, well, which way should the curve point? And I always tell them, point it up to God. If you point it up to God, you're pointing in the right direction. It'll get you. And so that's an important thing to remember. So many times you'll find the patient is admitted to your service, has a lot of blood in the urine, hematuria, and you know, you have to decide what you're going to do about the hematuria. Again, please don't put in a 16 French catheter. You're not helping the patient, you're not helping yourself, you're not helping us. All we're going to have to do is replace it with a bigger catheter. So think about using a bigger catheter that you can irrigate clots through. Anything from about a 22 on up would be a good way to go. I know that sounds horrible, but it's more horrible not to be able to irrigate clots. And so now there are 2 types of catheters. One that requires irrigation, but in all cases they usually require irrigation. So the two-way catheter, I think it's very important that the catheter is patent and that it requires frequent, observation to make sure that it's draining. This kind of catheter does not have the help of anything except at the output of the patient's urine. So if he's got an IV and if he's drinking fluids, push it to him and let him be well hydrated, if you will. The other thing is, when you irrigate these catheters for blood and clots, don't use these bulb tip syringes because you can't generate any kind of pressure with them. Use these, what we call Toomey syringes or catheter tip syringes, because then it's a piston, and then you can push in water, pull it out. And you got to use a fair amount of force because these clots can be tenacious. They can be difficult to get out, and so don't use any of these bulb tip syringes. Use a good piston syringe. And if the patient, doesn't have an IV, then suggest that they remain well hydrated. Again, this is one where you're going to have to watch it to make sure it doesn't get clogged. Now, if you're dealing with a lot of blood, a lot of clots, I would think about the larger three-way catheter. And again, this is a system whereby you have some fluid, whether it's saline or whatever, it's coming into the bladder, hopefully washing out the bladder and then going out the catheter. So you've got this continual irrigation going through. And it helps keep the urine flowing. But it's very important that you have removed all the clots out of the bladder here because if you haven't, the clots will block the catheter. You're pushing in fluid through the three-way, right? And then the bladder is just getting bigger and bigger and bigger. Patient's more uncomfortable. So I always tell my nurses, be sure that you've got as much clot out as you can before you start a three-way. And once you start a three-way, keep an eye on it, because if it blocks off, the patient's going to be hollering in the very near future if you don't do that. Now, pretty simple to decide when you're doing this three-way catheterization, the speed of the organ. Initially, we have it wide open, flowing through there. And as the urine starts to go from red to pink to light pink, you turn down the speed of the irrigation. And then at some point in time, if you stop the irrigation, the urine is staying clear. Probably means you can discontinue the catheter and get it out if the patient doesn't require it, or that you can stop the irrigation altogether. So a lot of docs are very concerned about INO, and a lot of our elderly patients understand that. I'm just going to tell you this is much easier to do with a two-way than it is with a three-way. Virtually impossible to do with a three-way. I'd use the kind of things that y'all always use: patient's weight, rails and breath sounds and edema and stuff like that to categorize how well you're doing on fluids. But you're not going to be doing it on INO with the three-way system. Virtually impossible to do. So, a lot of these patients with catheters will get these irritative symptoms. They're having spasm, they're uncomfortable, and it's usually related to the fact that the balloon sits right on the trachea. And so when it does that, it gives the patient the sensation that they have to urinate. The bladder's trying to push out this balloon, and this can be a bit of a problem. So what you have to do is make sure, first of all, the catheter is patent. If the catheter is patent, then there's a number of things that we can try for these bladder spasms or these irritative symptoms. Certainly some of the oral meds. Some of these meds are useful for the spasms, but not so useful for the mentation, right? They cause cognitive issues with our patients, and we'll talk about that in just a minute. But there is the potential use of what's called B&O suppositories, or belladonna and opium suppositories. These, again, I think you have to be careful to use a half grain, 30 milligram suppositories in the elderly patient, because a 1 grain of the opium part of this drug can be pretty hard on the elderly patient. But it is really effective for bad bladder spasms. And then there's some spasms you're just not going to make any better. The best thing you can do is get the catheter out. So, but these are things that you can try, pretty simple stuff. If none of that is working, give us a holler and we can help you with that. Let's see here. So there's these things that you're probably seeing with the increasing degree of frequency, percutaneous tubes. We usually have the radiologists, our friends in interventional radiology, help us place these. They're usually either put in the kidney or in the bladder, depending on where we need them. When they're in the kidney, they don't require very much irrigation, and it usually should be gentle irrigation. So again, what's going on is you have this catheter being put in from the back, through the subcutaneous tissue, into the kidney, and into the renal pelvis. And usually, we put in a wire first, and then we pass the catheter. When this catheter is going to be straight, we pass it over the wire. When we remove the wire, this catheter has membrane, does this little J in the kidney, and all these little portholes allow the urine to come out. That situation we talked about with an obstructed kidney and infection behind it, this is a great way, particularly the pressure, patient has a pressure of 60 and anesthesia won't touch him, great way of getting him out of trouble in the middle of the night. These are usually anchored to a little bed like this, a little bag, and my partner Suprapubic likes to speak Spanish, so everything's in Spanish here. Anyway, this just to show you where it goes and how it is. And so some of these, because they have little bitty bore, these are usually 8 to 12 French, can get obstructed with blood, with debris, what have you. So it's just a matter of putting in about 10 cc's and getting them free of any obstruction. So retention, gosh, in your population of patients, a very, very common issue. Obviously, it can be from a number of different etiologies, but you can't leave these patients in retention for a long period of time. They start to get upper tract damage. Sometimes they come in with a bilateral hydronephrosis, a creatinine of 20, and sometimes you can, when you drain them acutely, you can reverse the process, but it can be a dangerous situation. So the bladder needs to be emptied by some approach, whether it's by a catheter or by a needle, again, a percutaneous approach into the bladder if the guy has strictures or we just can't get in from below for whatever reason. So the only other important thing I would mention to you is that once you put a catheter in somebody's bladder and you drain it, let us know how much was in there. So that's going to determine when we take the catheter out. If it was a small amount of urine, probably get it out in a couple of days. If it was 2 liters, we're not going to get it out, likely in anything less than a month or 2, because that bladder has been stretched to the point where the muscle is no longer viable. So I think that very important for you to at least have your nurse or you document patient was drained of 400 cc's or 3 liters of fluid. It's an important thing for us as we follow these patients going forward. These tubes in the bladder can be put in by radiology, just like they put it in the bladder. They can put it into the bladder, or we can put them in surgically. These suprapubic tubes, whichever it is, by radiology or by us, these tubes cannot be changed any sooner than 4 weeks. They have to mature their tracks. Once they mature their tracks, you can take a catheter out, put another catheter in pretty easily. Important point here is that that track can close. So if the suprapubic tube comes out in the middle of the night, we need to replace it in the middle of the night. Because if you wait till morning, that track is going to close. You'll require another surgical or radiologic intervention to get the bladder drained again. So these suprapubic tubes are important from that standpoint, is they need to be changed when they fall out. They're very easy to change, even easier than a Foley. So last thing I wanted to talk to you, and that's all the overactive bladder issues that we see in the senior population, is that we know that medical therapy with these patients can be less than optimal. Certainly they can, at least here at the VA, we have a limited formulary. The drugs that we do have can significant side effects with dry mouth and constipation, and certainly the cognitive issues, the mentation issues are a bit of a problem. So this is a shameless plug for something we're calling percutaneous, posterior tibial nerve stimulation. And you've heard about stimulation, neuromodulation of the bladder with these things that we put, and we anchor the wires into the sacrum. This is really a much easier way to do this as an outpatient. What we do is we put this little neuromodulator and we stick it right here on the posterior tibial area where the nerve runs, and then we turn the modulator on for 30 minutes. And for whatever reason, we get retrograde flow stimulation of the sacral plexus by this nerve. And so a lot of these overactive bladder symptoms can be modulated this way. So it's for 30 minutes for 12 different therapies. And a lot of these patients are much better. They require maybe an occasional little treatment once in a while to keep them happy. We just got this here at the VA in the Department of Urology, and we'd love to be able to try this on a bunch of patients. We had this in private practice. It's really a very nice, when it works great. Keeps them off of medication. And so it's called PTNS, posterior tibial nerve stimulation. And again, we have it in our clinics, and I'd be glad to help you with that. Any questions I can answer for you? Admittedly, this was not a presentation I did necessarily for geriatricians. I gave this presentation to the nursing staff recently, but they thought it was so good that when you didn't have a speaker, they suggested that I give this to you. So I did amend it a little bit for you. But next time you ask me to speak for you, I'll give you a real formal urology talk and talk about issues that are germane to the geriatric population. Any questions I can answer for you? Yes?
So if we were referring a patient for that PTNS, would we just do it through the urology
Sure,
consult
you
menu?
can do it through CPRS and just say, patient with overactive bladder or even urge incontinence,
Yeah,
please see for potential PTNS.
okay.
We'll pick it up.
Yeah. And like in the perfect world where you actually had access to whatever overactive bladder drugs, do you think that any of them are less, have fewer side effects, and if so, which ones?
The bulk of medication for overactive bladder and these spasms and urge incontinence have been the anticholinergics for the longest. There is a new drug out there, not new, it's been around for a little bit over 2 years now. It's called Geriatric. And it works on the beta system. It's a beta blocker, much like metoprolol is. And only it blocks the beta receptors in the bladder. So these patients do get good relief without the dry mouth, without the constipation, without all that. And there are a few contraindications of giving it. The biggest one is that it's expensive. But in a perfect world, if the pharmacy plan covers it, it would be ideal. And actually, we're going to make a plea for it here because of the huge numbers of senior patients with mental issues. And so it's ideal for that. It really is.
Yeah, I have a patient that takes that now. I'd never heard of it until he was telling me about it, and he basically failed. He was seeing a non-VA urologist, and he basically failed every anticholinergic you can think of, and he said this works really well for him.
Yeah, when it works, it's wonderful, and the patients love it. Admittedly, it doesn't work for everybody, but it's a great drug to try, and I use it primarily in patients. I used it in the private practice setting because so many of their plans did pay for it. But it's just an alternative for you going forward. Anything else? If not, thank you very much for asking.
If you haven't signed in, now's a good time.
Mark, did you get it?
Yes, sir. Thank you very much.
You're welcome. Thank you for asking, and again, I'll be around in the future if you need me, okay?
Appreciate it.
Thanks.
Thank you. Appreciate that. You're welcome. Thank you. Yeah. Glad you enjoyed it. See you guys later.
Excellent. Thank you very much.
Yeah, I do.